Cardiopulmonary resuscitation. Cardiopulmonary resuscitation, CPR, is an emergency procedure that combines the chest compression, often with artificial ventilation, in an effort to manually preserve intact brain function until future measures taken to restore spontaneous blood circulation and breathing in a person who is in cardiac arrest. It is recommended in those who are unresponsive with no breathing or abnormal breathing, for example, agonal respirations. CPR involves chest compressions for adults between 5 centimeters and 6 centimeters deep and at a rate of at least 100 to 120 per minute. The rescuer may also provide artificial ventilation by either exhaling air into the subject's mouth or nose, mouth-to-mouth resuscitation, or using a device that pushes air into the subject's lungs, mechanical ventilation. Current recommendations place emphasis on yearly and high-quality chest compressions over artificial ventilation. A simplified CPR method involving chest compression is only recommended for untrained rescuers. In children, however, only doing compression may result in worse outcomes because in children the problem normally arises from respiratory rate rather than cardiac problem. The cardiac problem. Chest compression to breathing ratios is set at 30 to 2 in adults. CPR alone is unlikely to restart the heart. Its main purpose is to restore partial flow of oxygenated blood to the brain and heart. The objective is to delay tissue death and to extend the brief window of opportunity for successful resuscitations without permanent brain damage. Administration of an electric shock to the subject's head, termed defibrillation, is usually needed in order to restore viability or perfusing heart rhythm. Defibrillation is effective only for certain heart rhythms, namely ventricular fibrillation or pulsatiless ventricular tachycardia, rather than asystole or pulsatiless electrical activity. A yearly shock, when appropriate, is recommended. CPR may succeed in including induction heart rhythm that might be shakeable. In general, CPR is continued until the person has a return of spontaneous circulation or is declared dead. CPR is indicated for any person unresponsive with no breathing or breathing only in occasional gestures, as it is most likely that they are in cardiac arrest. If a person still has a pulse but is not breathing, respiratorized, artificial ventilation may be more appropriate, but due to the difficult people have in accurately assessing the presence or absence of a pulse. CPR guidelines recommended that lay person should not be instructed to check the pulse while giving healthcare professionals the option to check a pulse in those with cardiac arrest due to trauma. CPR is considered fatal but still recommended, correcting the underlying cause such as tension, pneumothorax, or pericardial tamponade may help. CPR oxygenates the body and brain for defibrillation and advanced life support. Even in the case of a non-shockable rhythm, such as pulseless electrical activity, where defibrillation is not indicated, effective CPR is not less important. Use it alone. CPR will result in few complete recoveries, so the outcome without CPR is almost uniformly fatal. Studies have shown that immediate CPR followed by defibrillation within 3-5 minutes of sudden with a cardiac arrest dramatically improves survival. In cities such as Seattle where CPR training is widespread and defibrillation by EMC personnel follows quickly, the survival rate is about 20% for all causes and as high as 50–70% if witnessed shockable arrest. In cities such as New York without those advantages, the survival rate is only 5% for witnessed shockable arrest. Similarly, in hospital CPR is more successful when arrests are witnessed or are in the ICU or in patients wearing head monitors, where the arrests are noticed immediately. In adults, compression-only CPR by bystanders appears to be better than chest compression with rescue bracing. Compression-only CPR may be less effective in children than in adults, as cardiac arrest in children is more likely to have a non-cardiac cause. In a 2010 prospective study, in 2010 prospective study of cardiac arrest in children age 170 for arrests with a non-cardiac cause provision by bystanders of conventional CPR with rescue breathing yielded a favorable neurological outcome at 1 month more often than did compression-only CPR. For arrests with a cardiac crash in this cohort, there was no difference between the two techniques. This is consistent with American Heart Association guidelines for parents. When done, be trained responders, treating compression interrupted by two breathing breaths appears to have a slight better result than continuous chest compressions with breath being delivered while compressions are ongoing. There is a higher proportion of patients who achieve spontaneous circulation, where their head starts basing on its own again, then ultimately survey to be hired from hospital. See table above. Measurement of end-tidal carbon dioxide during CPR reflects cardiac output and can predict chances of ROICs. 59% of CPR surveys live it over a year. 44% live it over 3 years, based on a study of CPR done in 2008. Performing CPR is advised as a last resort intervention for when a person is not breathing and therefore would sustain the without it. Survival rates in USA hospitals in 2017, 26% of patients who received CPR surveyed to hospital discharge in 2017 in the USA outside hospitals. 16% of people whose cardiac arrest was witnessed surveyed to hospital discharge. Science 2003 with spirit calling of patients after CPR and other improvements have raised cerebral and reduced mental disabilities. Mental abilities about the same for surveys before and after CPR for 89 of patients based on before and after counts of 20,000 500 patients cerebral performance category codes in a 2009 study of CPR in hospitals. 1% more surveyors were in comas than before CPR. 5% more needed help with daily activities. 5% more had moderate mental problems and could still be independent. For CPR outside hospitals, a Copenhagen study of 2,504 patients in 2011 found 21% of surveys developed moderate mental problems but could still be independent, and 11% of surveys developed severe mental problems, so they needed daily help. two patients out of 2,504 went into comas, and the study did not track how long this comas lasted. Organ donation is usually made possible by CPR, even if CPR does not save the patient. If there is a return of spontaneous circulation, all organs can be considered for donation. If the patient does not achieve thorax, ROSC, and CPR continues until an operating room is available, the kidneys and liver can still be considered for donation. 1,000 organs per year in the USA translated from patients who had CPR. Donation can be taken from 14% of patients who have ROSC and later become brain dead. Up to 8 organs can be taken from each donor, and an average of organs are taken from each patient who donates organs. Most people in coma start to recover in 2 to 3 weeks. 2018 guidelines on disorders of consciousness say it is not longer appropriate to use the term permanent vegetable state. Mental abilities can continue to improve in the 6 months after discharge and in subsequent years. For long-term problems, brains from new patches to replace damaged areas. Injuries from CPR vary. 87% of patients are not injured by CPR. Overall injuries are caused in 13% of patients, including broken sternum of ribs, lung injuries, and internal bleeding. The internal injuries can include heart contents, hemopericardium, upper airway complication, damage to the abdominal viscera, lacerations of the liver and spleen, fatty emboli, pulmonary complication, pneumothorax, hemothorax, lung contusion. Most injuries did not affect care. Only 1% of those given CPR received life-threatening injuries from it. Broken ribs are present in 3% of those who survey to hospital discharges, in 15% of those who die in the hospital, for an average rate of 9% to 8%. In the 2012 study, 20% of surveys were older than 75. A study in the 1990s found 55% of CPR patients who did before discharge had broken ribs, and a study in the 1960s found 97% did. Training and experience levels have improved. Lung injuries were caused in 3% of patients of the and other internal bleeding in 3%. bones heal in 1-2 months. Training and experience levels have improved since the study in the 1990s, which found 15.5 broken ribs among CPR patients who did before discharge, and the study in the 1916s, which found 97%. The costal cartilage also breaks in an unknown number of additional cases, which can sound like breaking bones. In the type and frequency of injury can be affected by factors such as sex and age. 1999 Australian study of CPR cadavers using machine which alternately compresses the chest, they pulled it outward, found a higher rate of sternal fractures in female cadavers than male, and found the risk of rib fractures rose with age. Thus, uh, they did not say how much children and infants have a low risk of rib fractures during CPR, with an incidence less than 2%. Also, when they do occur, they are usually anterior and multiply, where CPR is performed in error by a bystander on a person not in cardiac arrest. Around 2% have injury as a result. Also, 12% experience discomfort. At 2004, very said chest injury is a price worth paying to achieve optimal efficiency of chest compressions. Caution of faint-hearted chest compressions may save bones in the individual case, but not the patient's life. The most common side effect is vomiting, which necessitates clearing the mouth, so patients do not breathe it in. It happened in 16 of 35 CPR efforts. In a 1989 study in King County, Washington State, USA. In 2010, the American Heart Association and International Liaison Committee of Resuscitation updated their CPR guidelines. The importance of high-quality CPR was emphasized. The order of intervention was changed for all age groups except newborn from airway breathing the compressions ABC to chest compressions airway breathing. An expansion to this recommendation is for those believed to be in respiratory arrest, airway obstruction, and drug overdose. The most important aspect of interruption of chest compression is sufficient speed and depth of compressions, completely relaxing pressure between compressions, and not ventilation too much. It is unclear if 5 minutes of CPR before defibrillation results in different outcomes than immediate defibrillation. A universal compression to ventilation ratio of 32 is recommended for adults with children if at least 2 trained rescuers that present a ratio of 15 to is preferred. According to EHA 2515 guidelines, in newborns the ratio is 30 to 2 if one rescuer and 15 to if two rescuer. If an advanced airway, such as an endotracheal tube or pharyngeal mask airway is in place, artificial ventilation should occur without pauses in compression at a rate of 10 per minute. The recommended order of intervention is chest compressions, airway breathing or CEP, and in most situations with a compression rate of at least 100 per minute in L groups. Recommended compression depth in adults and children is at least 5 centimeters, and in infants it is 4 centimeters as of 2010 the Recession Council UK still recommended ABC for children. Yes, it can be difficult to determine the presence or absence of a pulse. The pulse check has been removed for lay providers and should not be performed for more than 10 seconds by healthcare providers. In adults, rescuers should use 2 hands for their chest compressions, while in children they should use 1, and with infants 2 fingers, index and middle fingers. CPR training. CPR is being administered while a second rescuer prepares for defibrillation. For adults with cardiac arrest, compression only, hands only, or cardiocerebral resuscitation. CPR, which involves chest compressions without artificial ventilation, is recommended as the method of choice for the untrained rescuer of those who are not proficient as it is either to perform, and instructions are either to give our iPhone in adults without of hospital cardiac arrest. Compression only CPR by the lay public has an equal higher success rate the standard CPR. It is hoped that the use of compression only delivery will increase the chances of the lay public delivering CPR. Compression only CPR is not as good for children, who are more likely to have cardiac arrest from respiratory causes. 2 reviews have found that compression only CPR had no more success than no CPR without breath for children, and special for babies should be relatively gently. Is there a ratio of compression to breath of 32 or 15 to was found to have better result for children. Both children and adults should receive 100 chest compression per minute. Other expression by that children includes case of drownings and drug overdose. In both these cases, compression and rescue breath and recommended if the bystanders is trained and is willing to do so. As per the American Heart Association, the beat of the BSG's song Stay Alive provides an ideal rhythm in terms of beats per minute to use for hands-only CPR, which is 104 beats per minute. One can also hum Queens, another on Beats the Dust, which is 110 beats per minute and contains a memorable repeating drum pattern. For those in cardiac arrest due to non-heart related causes and in people less than 20 years of age, standard CPR is superior to compression-only CPR. Standard CPR is performed with the person in supine position. Prone CPR or reverse CPR is performed on a person lying on their chest by turning the head to the side and compressing the back. Due to the head being turned, the risk of vomiting and compression caused by aspiration pneumonia may be reduced. The American Heart Association currently guidelines recommends to perform CPR in the supine position and limits prone CPR to situations where the patient cannot be turned. During pregnancy, when a woman is lying on her back, the uterus may compress the inferior vena cava and thus decrease venous return. It is therefore recommended that the uterus be pushed to the woman's left. If this is not effective, as for rule, the woman uh, 30 grados of healthcare professional should consider emergency resuscitative hysterectomy. Interposed abdominal compression may be beneficial in the hospital environment. There is no evidence of benefit pre-hospital in children. Cooling during CPR is being studied as currently results unclear whether or not it improves outcomes. Internal cardiac massage is manual squeezing of the exposed heart itself carried out through a surgical incision into the chest cavity, usually when the chest is already open for cardiac surgery. Active decompression methods using mechanical decompression of the chest have not been shown to improve outcome in cardiac arrest. Thank you for listening. Goodbye.